Well, good morning and welcome. Thank you so much for joining us. Not sure if it's morning, afternoon, or evening where you are, but we are so glad to have you here with us for COVID-19, what the science is telling us. So we're going to jump right in to welcome and thank you so much for attending. The foundation staff who is going to be on this, participating in this webinar is myself. I'm Holly Preeb, and I'm with the foundation Chief Operating and Financial Officer, and Autumn Lintz, who is our Education Manager. We're excited to be here with you and look forward to facilitating the webinar today. So yes, we are accepting Q&A. We're very excited to offer you the opportunity to include your questions as the doctor wraps up with her presentation. The Q&As, feel free to add them to the Q&A function at the bottom of your screen. I believe it's at the bottom of the screen as a tool. It says Q&A. Please enter your questions there, and we will facilitate those as the presentation concludes. Yes, also, we are recording the program. If you have to jump out and you want to watch it back, or if you feel like you might have missed something, please feel free to visit our YouTube channel at any time, and it will be available there. We want to make sure that we thank our individual donors as well as our funding partners for making these programs possible. It isn't possible without the generous donations of individuals and funding partners for us to be able to host these events. So thank you to all of our donors. It's my honor to introduce you to Dr. Jasmine Zain, the director of the T-cell lymphoma program at City of Hope National Medical Center. She has a specialty in hematology and oncology. Dr. Zain is a triple board certified hematology, oncology, and internal medicine, is an active member of several professional associations, and has published more than 78 peer-reviewed publications, abstracts, and book chapters. Dr. Zain is a highly accomplished clinician and clinical researcher in cutaneous lymphomas. Dr. Zain is also a very valuable member of the Foundation's Medical Advisory Board, including spearheading our COVID task force. She's a content contributor, speaker, and assists with our incoming patient inquiries. We are so grateful. We hope that you will join us in welcoming her today. Dr. Zain, welcome.
Good morning, good afternoon, good evening, wherever you are. It's a pleasure to be here. And I will be talking today about some of the issues with COVID-19 and particularly focusing on the vaccinations and some of the side effects. And I welcome your questions. So to start with, I just want to sort of go over what COVID-19 illness is, because I think it's important to understand that before we start thinking about vaccinations and side effects, because I know that that's a big question in everybody's minds, the side effects and whether to take the vaccine or not. So SARS-CoV is an RNA virus. It's a coronavirus, and viruses basically are just sort of particles of DNA or RNA. They really don't exist without them, without a host. I mean, they do exist, but they really can't function without a host. So they really need a host in order to propagate. And like any living thing, they want to divide and propagate. So that's why they attack us, because they use our cells for that purpose. So this particular virus gets into the nose. It's thought to be transmitted through droplet infection. There may be concern that some of the variants may be airborne as well. Nonetheless, once it enters the nose, it actually has these, by itself, it's sort of an RNA that's packaged in some very small number of proteins. And one of these proteins will then get attached to, it's called the spike protein. It sticks out like a spike, like a crown, as you can see in the picture. And then this spike will then attach to a receptor in our nasal passages called ACE2, ACE2. This then sort of allows it to enter our cells. Once it's inside the cell, the virus will then basically hijack the cell's protein synthesizing machinery and start replicating inside the cell using the cell's machinery, and then starts releasing more of these particles that get into our system. And then because it's gotten through our nasal passages, it'll first affect the lungs. So the symptoms are usually a sore throat, runny nose, cough, things like that. Maybe a little bit of fever. But then the real problem starts, because once these viruses or this particular virus enters our cells and this starts attacking other parts of our, other organs or other cells in the organs, these viral peptides and proteins get released as the cells die or get inflamed. And this then induces an immune response. So the immune response, as you may or may not know, is a very complex system of cells and proteins, including B cells and T cells with different functions, and they all come into play, and you have a major immune response. Some of it includes an antibody production to sort of fight against and kill any of the subsequent virus that may be encountered, or it may be also in the form of T cells that will chew up or kill these viruses or virus-containing cells even later on the future. And the goal of all this in our body, so the body is fighting the virus, the goal of the body is to have a defense mechanism to kill the virus anytime it encounters it, whether it's during that infection or a subsequent infection. And an effective immune response would also include a memory response, so that down the line in the future, if you get encountered this virus, you can mount an immune response to it. So that's kind of where the whole effect of this virus happens. Unfortunately, as the body mounts an immune response, that's where a lot of the dysfunction comes in, because that immune response is so exaggerated in these patients sometimes. And again, it's because the severity of the infection is so much, and it's such a new virus to the human race, that response itself can cause an illness. And that's where you see a lot of the inflammatory responses, inflammatory problems that you see with COVID patients, the pneumonias, the ARDS, and the multi-organ dysfunction, which I'll show you on the next slide. Can you move the slide, please? Next slide. Holly? Next slide. Okay, sorry. So this, okay. So this is where you actually sort of graphically see the sequence of infections. You get it, patients get an infection. The virus can be isolated early on in the respiratory secretions, in the nasopharynx and things like that for the first few weeks. And then the virus kind of goes away. You may not be able to detect it anymore because the body has mounted an immune response. But then, during this time, the patient will be PCR positive and then becomes PCR negative. But at that point, you start having, or you may start having, or even before it becomes completely PCR negative, you may start having some of these inflammatory problems like pneumonia, and then the brain issues, sort of like confusion, anxiety, depression, cognitive disturbance, headaches, heart palpitations. This is where all the myocarditis and all those other issues come in. The blood vessels get affected, so we can have blood clots that can lead to strokes and heart attacks and kidney dysfunction, hair loss, also can affect your endocrine organs. So a lot of this stuff that's happening later on in this process is really an immune response, a very exaggerated immune response to the virus that has been seen in many patients, and actually has led to a lot of deaths. So there's two parts of the infection: the initial infection, which may or may not clear completely, and then this immune response that happens and can be ongoing and can be devastating if not controlled. And this is where drugs like, so in terms of the treatments, the monoclonal antibodies help around here to control the infection so that this immune response is not as exaggerated. And then you have drugs like tocilizumab and decadron and dexamethasone and other anti-inflammatories that can help with this part of the infection. So then sometimes people end up with this chronic it's called the chronic post-COVID syndrome. About 30 to 40% of the patients end up with that, with scarring of the lungs and damage to the kidneys, and that's a very unfortunate stage. Next slide, please. Okay, so again, this is a slide showing some of the different organs that are affected eventually with SARS-CoV. As you can see, almost every organ in the body is being affected by this infection or the inflammation from the infection, including the skin, lungs, GI tract, heart, muscles, even eyes, congestion, and including the reproductive system. So, there is a lot of concern about, and we'll talk more about it, the vaccines causing infertility and so on. I think the part of the problem is it's not just the vaccines we don't know for sure, but we do know that the infection can affect the reproductive system. And of course, the fevers and things like that that can happen with the infection. As we all know, fevers are detrimental to a pregnant patient. They can lead to fetal and embryonal losses, and it's just not, any pregnant woman with a fever is a serious situation. Next slide. Okay, so let's talk a little bit about the vaccines. So the vaccines come in a couple of different flavors and different methodologies. So again, I want to emphasize that these vaccines that we have developed for, or have been developed for COVID-19, are really built upon years and years of science and years of research that has been ongoing to develop vaccines for different things, including AIDS viruses, other coronaviruses, the MERS and the SARS viruses that happened a few years ago. So it's not, when people say these are new vaccines, that's not necessarily completely true. The technology and the methodology for these vaccines has been ongoing for a very, very long time. The only silver lining in this whole pandemic is that it has really given a big boost to vaccine research. And as you know, recently, because of all the research that has been done for the COVID-19 vaccine, there's now a malaria vaccine. There's a push to develop vaccines towards other viruses. Perhaps there'll be a vaccine for HIV pretty soon. So these methodologies are pretty interesting, and I wanted to point that out to you. So this messenger RNA vaccine by the Pfizer and Moderna is a completely sort of new form of vaccine, and it's pretty cool if you think about it. So the way this has been developed is that they actually took the spike protein. So remember, the spike protein is one of the proteins that's shed from the virus and leads to an immune response. So what if you could introduce that protein into the body without the virus and get that immune response? That's the whole goal of vaccination, is to have an immune response without the infection. So they take the spike protein, and then they are able to find out what the RNA sequence is to make that protein, because it's much more efficient to introduce the blueprint or the sequence into the body. So that RNA is then packaged into a vaccine, into an artificial virus, so to speak, and injected into our body, where it is actually taken up by our muscle cells. So in the deltoid muscle, when the injection happens, the muscle cells take up this RNA, which then gets incorporated into the muscle cell, and the muscle cell actually starts producing the spike protein. So you may have seen those, ads or cartoons where they say, "I make the spike protein now." So the spike protein is now being generated by our muscle cells. There's no virus, there's no DNA. It's just, using the machinery for the virus from the muscle cell, and the muscles make lots of proteins all the time. So they just make this spike protein, and our immune system recognizes that protein as being foreign, and it mounts an immune response. And that's pretty much how we make the antibodies and other immune responses, hopefully cellular immune responses as well, against these vaccines. And the boosters are given to sort of augment that. There's a 2 vaccine course, and then the boost to basically just augment that, and go with the goal again being to have a memory. So now you've developed an immune response without having to be infected by the virus and putting yourself at risk for all that post-inflammatory, post-viral inflammation and the long COVID syndrome, but you have immunity. So this is the principle for both Pfizer and Moderna vaccine, which in my opinion is very cool. Next slide. But there are other ways to make virus vaccines as well. So Johnson & Johnson, AstraZeneca did another methodology. They basically took the viral vector protein. They just took the spike protein, and again, it's much more efficient to use the blueprint. So they took the blueprint. This time they actually injected it or introduced it into a harmless adenovirus. And this technology again is being used for many other. The flu virus is also made that way. So many other ways, other vaccines are made this way. Sorry, a flu vaccine. So this is an older technology. So this adenovirus now has the spike protein RNA or genetic material to make spike protein, but it's harmless to the human beings. It's injected into the body. Again, this virus enters the cell, just like a COVID-19 virus, SARS-CoV virus would. It starts making the spike protein, and then we mount an immune response. So essentially the same thing, like the messenger RNA, except this time the packaging is a little bit different. Again, in my opinion, the messenger RNA is way cooler, but I'm a geek. So next slide. Another way is that this is the Novavax. This has not been released yet, but this is basically using protein subunits. So this is actually pretty cool. I think it's coming down the line where they actually just take part of the spike protein, not the whole protein, the part that's actually the most important part in inducing an immune response, because obviously not the whole protein, but the parts of it we know are more immunogenic. And they just take that and then use that inject that into bacteria or animal cells and produce this protein, and then use either a vehicle like a nanoparticle or something like that to inject those protein pieces into the body to induce an immune response. And this we expect, at least from what I read, could have fewer side effects, and because you're not introducing the whole protein, you're introducing just this, and it could actually be even be used to be a pan coronavirus type of vaccine. So this is coming down the line. There's a couple of other methodologies where in other countries they're using an inactivated coronavirus itself for the vaccine. I believe that's the Chinese and maybe even the Russian vaccine. So there's different ways to do vaccinations, some more effective, some not. But most of these vaccinations are designed to have an immune response so that when we do get exposed to the virus, which we are all at the moment risk of, we will have enough immunity to prevent us from getting very sick. That graph I showed you, we want to hold the virus back before it gets to that severe inflammatory state that ends up, makes us end up in the hospital or may even lead to the death of the patient. So if we can control the infection early on with our own immune system, which has already been primed, we will avoid some of the complications of this disease. We may not be able to avoid the infection, but we should be able to avoid the complications, which is what the vaccines are designed for. Next slide, please. So having said that, I wanted to talk about vaccinations in the context of lymphoma patients, particularly cutaneous lymphoma patients. So this has been an ongoing area of research in terms of how do patients respond to these vaccines? Because we do know that patients with lymphoma and other malignancies, but lymphoma in particular, and particularly B as in boy cell lymphoma patients, have a weakened immune system. And we give them drugs like rituximab, which again doesn't apply so much to mycosis fungoides, but certainly some patients with B cell skin lymphomas may be getting rituximab therapy. But there's multiple studies that have shown that patients who have non-Hodgkin's lymphoma, particularly B cell malignancies, their immune systems are so weak that they cannot control the infections, even the initial infection, and their outcomes are really bad. Now, their immune response, again, may be a bit weaker, as I mentioned, which may also mean that the virus doesn't get controlled early on and causes widespread devastation. The initial studies were coming out of Italy because, as you know, there were a lot of, the initial pandemic was very, it's kind of a lot of the patients that died in Italy. So there was a lot of studies that came out of there. So if you have a history of cancer, particularly lymphoma, it seems like your outcomes from SARS-CoV-2 infection are a lot worse, particularly if you've had anti-CD20 based therapy, which is rituximab. So even in the United States, ASH, which is the American Society of Hematology, is collecting data, and they've published outcomes of heme malignancy patients with COVID-19 infection. All of them have the same message. Patients with cancer undergoing chemotherapy, undergoing immunotherapy, do worse. Next slide, please. So what about vaccinations in these patients? Because if their immune system is weak, can they mount an immune response? And again, this is an ongoing area of research. We don't have all the answers. So I want to emphasize that first. We don't have all the answers. However, the recommendation right now is to offer vaccinations to all patients who are getting treated for lymphoma and other cancers, including patients with stem cell transplant and CAR T therapy after they've had, after these procedures, 3 months after these procedures. So the recommendation is still to vaccinate these people, but of course, everybody questions: is it going to make a difference? Is it going to mount? Are we going to mount an immune response? So it looks like there are some studies that are now starting to be published, and I've listed a few of these. It looks like a good percentage of patients do mount a response. So in one study, there was about 60% mounted an immune response by the methodologies where you can measure the immune response. So again, that is just another question, but looking at antibodies or T cell responses, they found that messenger RNA-based COVID-19 vaccines were resulting in some immune protection. Patients with with lymphoma who had not had any treatment seemed to do okay, or patients who had no treatment for the last 2 years seemed to have a good response to these vaccines. However, patients who are on anti-CD20 monoclonal antibodies, and these include rituximab, ublituximab, there's a couple of obinutuzumab, they did not mount any response, particularly if they received the vaccination within 6 months of treatment. So this was at least one study. But again, the data is coming. We're not completely sure about what to make of this, but it is concerning that patients who are on these particular specific treatments may not be mounting a response, and which means that even in spite of vaccination, you need to continue the precautions. Next slide, please. Next one. Next slide. Okay. Now, there is some concern. I'm sorry about this. No, go back. Go back. Back. Sorry about this technical difficulty. Anyways, this is a bunch of yesterday when I was preparing this talk, I wanted to look at what publications were out there for association of lymph node enlargement and COVID-19 vaccine. We do know just from experience from colleagues that there is some lymphadenopathy that's been noted, which means enlargement of lymph nodes after the vaccinations. Is this concerning? So there's actually a lot of data out there that shows that there is significant amount of lymph node enlargement noted after vaccinations. That's been picked up on PET scans, CAT scans, even clinical examinations. And again, this is important because, as you know, we use PET scans to evaluate lymphoma, or progression of lymphoma and treatment effects and so on. So it has to be kept in mind that the vaccination can actually result in enlargement of lymph nodes. It does not result in worsening of lymphoma. These are all benign nodes that actually resolve within 4 to 6 weeks. In fact, there are now recommendations that people who are getting mammograms should delay them for about 6 weeks after the vaccinations, because you can have this lymphadenopathy that could make you worry that what if this is cancer, and then you need a biopsy and so on. And I have even in my practice, I've seen a lot of patients having lymph node enlargement or worsening of their PET scans after the vaccination that actually goes away. So this is something to keep in mind and discuss with your doctor when you're doing your about the timing of your vaccination and your scans. Next slide. And now coming to the topic of cutaneous lymphomas and COVID-19 vaccination. I'm sure you guys are going to have a lot of questions about this. So there is some concern within the community that are lymphomas going to get worse with either COVID-19 or COVID-19 vaccination, particularly vaccination, and particularly what happens to CTCL. So again, there are mixed reports, and there's a lot of stuff on the internet. People do get rashes as a result of vaccination. It's a known side effect. There is lymph node enlargement, as I've mentioned. Some people even get fevers, fatigue. All of this is a side effect and known side effects of these vaccinations, or any other vaccination, in fact. But because this is a brand new virus, my thinking is that our immune responses are more exaggerated, so we're experiencing more side effects. In terms of whether it can make cutaneous lymphoma worse or better, all we have is anecdotal reports. And that is not really science. These are just reports. It just means that we have to be more vigilant. And actually, they go in both directions. So there was a report of a patient whose cutaneous T-cell lymphoma recurred after they got their COVID-19 vaccination. They had been in remission for about 2 years. And after the vaccination, they noted that the disease had come back. Whether there's a direct correlation between the vaccination and the recurrence of lymphoma is very hard to say, because this disease does wax and wane. There is another interesting report of regression of a cutaneous anaplastic large cell lymphoma after SARS-CoV-19 vaccination. So the immune system can go in the other direction as well. It can actually mount an immune response that becomes stronger and may get rid of some of these lesions. So that's, again, a single patient case report. There is a report that's not quite there yet, which is recurrence of a primary cutaneous CD30 positive lymphoproliferative disorder recurrence following COVID-19 vaccination. So these are, again, individual case reports. We as physicians and researchers should be reporting these so that we can keep track of this data. This will have to be compared with what the background rate of recurrence of these diseases is. Most of these lymphomas wax and wane naturally, and it could just be a coincidence. We don't know that, so it's very difficult to make any recommendations based on these very few case reports. And it's important to just keep track of these things. We do know that at the moment, the benefits of getting a vaccination are a lot higher than some of these risks. Even if there is a recurrence of these diseases, as you know, if it's a rash that comes back and is still cutaneous lymphoma or CD30 positive lymphoproliferative disorder, it can be treated. Whereas some of these complications of COVID could really be life-threatening. So in the overall picture at the moment, we still recommend vaccination. Next slide, please. Again, this is, no, I think it's the same slide. Next one. Is there another slide? Okay, so this is actually an interesting case that I wanted to share with you. This was published a few months ago, and this is a case of a 61-year-old patient who had Hodgkin's lymphoma, biopsy proven. Also had a history of kidney failure, so he was pretty sick and was getting some treatment, but he got admitted to the hospital with SARS-CoV-2 pneumonia, and basically was intubated and given the best supportive care and then discharged. He was not given any steroids and immunotherapy. This was before dexamethasone was being used to treat a lot of these patients with COVID-19 infection. But 4 months later, he had complete resolution of his disease by PET scan. And it was thought that SARS-CoV-2 infection triggered an anti-tumor immune response, which it can happen with lymphomas. So again, I wanted to point out that this is a one patient case report. We cannot make any kind of conclusions based on this. So other than in this particular patient, he was lucky, he got and good for him, and he got this response. I can tell you in my practice, I've seen patients. I had recently a patient with significant mycosis fungoides. He actually had Sézary syndrome, who was admitted with the COVID-19 pneumonia, recovered, and when he came to see me back after his infection was cleared, I think there was a 50% decrease in his skin symptoms, itching and inflammation. So this immune response is very tricky. It can go either way, and at this point, we don't know enough about it to make any kind of recommendations that veer away from what's being recommended by the CDC and the bigger scientific community. And we should follow those recommendations in terms of vaccinations. Of course, you should discuss it with your doctor. And, we are collecting the data, and hopefully we'll have more information about this as we move forward. And I think this is my last slide. And with this, I want to thank you, and I will take some questions. I can see there's a bunch of questions already.
Okay, I'm going to go ahead and read some of the questions.
Sure.
One of the first questions we had is, can you please address the issue of booster shots for patients with CTCL?
Great, great question. So the recommendation right now is to receive a booster shot if you've had, can you hear me still?
Yes.
To get a booster shot, if you've had your previous, first of all, it's only available for Pfizer, patients who got Pfizer. And after 6 months of their second vaccination, if they're immunocompromised or over the age of 65. So if you're over the age of 65, I think it's fine to get it. The second question is, would you consider a patient with cutaneous T-cell lymphoma immunocompromised? So that depends on the stage of the disease. I think very early stage disease, that's stage 1A perhaps, or even 1B, who's in patients who are not getting active systemic treatment, perhaps can forego the booster shot at the moment and not, not pursue it very strictly. I think people beyond 1B or those who are getting active systemic treatment should really consider it and discuss it with their doctor. The data for the efficacy of the booster shot is mixed, if I may say so. And even who I got my booster shot 5 days ago, debated whether I should get it or not. The reason I got it is because I'm a healthcare worker. But the data is not clear that it's actually that much more helpful than just having the 2 shots, because as I've showed you the immune response in my slides earlier, the idea is to get a memory-based immune response. Now, there is data to say that with just these, just with the vaccinations, the immune response may wane with time. Certainly the antibody response seems to wane with time, but we don't know what happens to the T cell response. So it's a bit difficult. The data is mixed, but the CDC recommends that you do get it. So I think at this point, I've tend to follow the bigger scientific community and do follow their recommendations. So I think if you're getting active treatment that's systemic, you're getting something like romidepsin, or you're getting, rituximab, or you're getting other kind of chemotherapy, or even, any immunotherapy type of things, you should probably get a booster shot. If it's early stage disease and you're just getting you have some patches and plaques, and you're under the age of 65 and otherwise not at higher risk, no diabetes, anything like that, then I think it's okay to wait it out a little bit longer and see. We'll have more data as time goes on. In 6 months we'll know more about these things than we do now. So we're learning as we go along.
Okay, thank you. Next question: can double vax patients host overnight guest family in their home for the upcoming holidays? What precautions must be taken?
Yes, that's a question that everybody asks me every day. So double vax patients, again, it depends on what you're getting, you're getting treated for. As I did show that vaccinations in patients with lymphoma may not be as effective as in a normal person. Again, I use the word may not. So the precautions have to be continued. I think if your guests are careful and they are vaccinated, and remember there's children as well who may or may not be vaccinated, then you have to think about the risk and the benefit and see what what is best for you. You don't want to end up being, getting sick from this party. I would say discuss it with your doctor, but I think making sure that people who come to visit you are vaccinated, or at least if they don't want to be vaccinated for whatever reason, at least have a negative COVID-19 test within 72 hours coming to visit you. I think that's a fair ask of a guest. I think in that case, and they're not sick otherwise, I think it should be okay.
Okay, thank you so much. Next question is: in my region, which is Canada, hematology patients are being urged to take a third vaccination to, quote, level the playing field for efficacy. Is this what you are recommending to your patients?
Yes, we are. As I mentioned, because their immune response may not be as strong as a non-hematologic malignancy patient. It is recommended that they get a third booster vaccine. It's just like when we, I don't know if people know people who get a bone marrow transplant, we revaccinate with all childhood vaccinations just because, to level the playing field. It's the same thing. So if you're getting treatment or if you have a hematologic malignancy, it is recommended you get another shot.
Okay, I have developed a cutaneous patch around the vaccination site. Is this something I should be concerned about, particularly if I'm getting the third vaccine?
If you're a patient of cutaneous lymphoma, is it just a rash in somebody else? I don't know for sure. But if it's a patient with, sorry, did they clarify that?
They have not yet clarified that.
Okay. I mean, you could possibly get a similar rash when you get your third booster. I'm noticing people, my colleagues and I are getting these vaccines nowadays, and some people have no problems, but most people are reporting similar reactions to the second shot. So if you had a rash before, you may get a rash this time. It's possible.
Okay, next question. Do you recommend that patients who are vaccinated prior to being 6 months off of, and I always butcher this one, rituximab, vaccinate again after 9 months? I cannot get that one out.
Can you repeat that question without the word? Just call it R.
Yes. Do you recommend that patients who were vaccinated prior to being 6 months off of R vaccinate again after being 9 months after R?
So I would discuss that with your doctor. I mean, most people have noticed that people who had received rituximab did not mount an immune response. And so some of my patients, especially the ones who've had a lot of rituximab, I am recommending that they get revaccinated, after 6 to 9 months after they finish their treatment. A lot of the times we have actually, because we kind of knew about this or suspected this early on, we actually stopped doing rituximab treatments, particularly in the maintenance setting for a lot of our patients, so they could get vaccinated. They let enough time pass so they could get an effective vaccination protocol without having rituximab on board. So yeah, your short answer is I would recommend you get vaccinated. Yes.
Okay, thank you. And thanks for pronouncing it. I just can't get that one right. So you partially addressed this in the presentation, and I'm wondering if maybe we just need a little more clarification, is have patients with cutaneous lymphoma who contracted COVID-19 shown increased cutaneous lymphoma disease activity afterwards? And I know you mentioned that there's only been a couple studies on it.
Not studies, case reports. Is a difference. Case reports are individual patient case reports that somebody observes and wants to publish so that people are aware of it. It does not mean that it's researched and it's a recommendation. So based on that, I don't think there's enough data to say that at all. I mean, I treat cutaneous lymphoma patients all day long, and I have not seen any major, for the vast majority, I have not seen any changes after vaccinations. So there have been, as I mentioned, there's been a few cases where things seemed a little bit better, at least one case, but not really. Again, a lot of this could be coincidental too. Remember, this disease wax and wanes, but we are collecting all this data. So it's going to be very difficult to prove the association with the vaccine, but we are collecting the data, and we'll compare it to the background rate of recurrence and see if there's a difference. So we'll know more about it as we go along.
Okay. Does lack of a reaction to the vaccine correlate with patients not building antibodies?
As I showed you, the antibody response is one part of the immune system. So yes, if you don't mount an antibody response, it's possible, again, it's possible that the immune response is not optimal. However, there is a whole other component of the response, which is the T cell response, which is actually a longer lasting response, which we don't measure very frequently. It's very hard to measure that. So I don't follow antibodies actually. My understanding from talking to the experts is that it's not very helpful. So there are commercial tests out there. I know some people follow these antibodies, but again, the bottom line is that we don't know if it correlates with the actual immune response. It may be just a small marker of it. And secondly, there may be a whole other component of the immune response that is not being measured. So I would say it's very difficult to answer that question. We don't really know. So.
Okay, we did have a clarification where when they had asked about patients with CL who contracted COVID showing increased CL activity, he was specifically asking about people who had contracted COVID-19 prior to being vaccinated. And I believe you already answered that. And okay. I want to address the person asking the question. If your question was not fully answered, please add in another question.
Okay.
Okay, so our next question, are CTCL patients at risk for further compromising or suppressing our immune system as we add additional COVID vaccines? Several online articles are ringing alarm bells.
I'm not sure. What is the question again? Is adding a booster, is that going to
yes, getting the booster, would that put CTCL patients at further risks of compromising or suppressing their immune systems?
We don't know the answer to that. So I'm not sure which online articles you're referring to. There's a lot of misinformation online, and we're learning about these algorithm issues on Facebook and other social media things where you can actually start getting more and more information or misinformation. I showed you the articles I found in the medical literature that's on the PubMed. These are peer review articles. I don't know if there's any additional risk of compromising the immune system. The vaccines themselves are immune augmenters. So it should actually, in my mind, the question really would be, is the response going to be more adequate? if the patient is more advanced. But I think the short answer in terms of affecting your immune system, I don't think the vaccine itself is going to make a huge difference. But you may be able to mount a good response. That's the bottom line.
Okay, thank you. And at this point, we don't have any other questions. So if anyone wants to try and sneak one in under the wire, please go ahead and type in your questions. Holly, do you want to start wrap up? And if anyone has a question at the last minute, we can jump back in.
I see 2 more questions. Is that, they've been?
Those have been addressed.
They've been, okay, all right. Okay.
I really just want to say thank you very much to Dr. Zain for your sharing your knowledge and expertise with the foundation and the people that we serve. You know, it's invaluable to be able to bring this information from a specialist in cutaneous lymphoma to the community. So thank you very much for your time and for being here with us. And then just in a closing and kind of information for our attendees. We ask because we care. You're going to receive a survey feedback. We appreciate if you would take the time as an attendee of one of our educational events here to provide us your information and feedback so that we can continue to improve our programs for you. If you haven't already, join the mailing list. You'll get updated information, newsletters, things of that sort. The website is a vast amount of vetted information, clinically vetted information that our Medical Advisory Council works tirelessly to ensure is accurate for your information. Community Connections is a great resource for peer-to-peer. So if you're looking for a peer-to-peer community, there is your spot. And then as always, please follow us on social media. Facebook, LinkedIn, and YouTube is where you can find us. And we hope to see you at a future program. Thank you so much for everyone being here. And thank you again, Dr. Zain, for your participation in this webinar.
You're welcome. Welcome. My pleasure. Thank you. Thank
Okay.
you. Be safe out there, everybody.
Yes. Bye-bye.